Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Size Matters, ACTH-dependent Cushing disease and its nuances, is presented today by Dr. Jamie Van Gompel of Mayo Clinic in Rochester, Minnesota. Now please hold as there will be a brief delay while we change presenters. Okay.
Can you see me?
We see you, yep.
Perfect. Well, hello everyone, and I want to thank the Pituitary Network Association again for the opportunity to present just some kind of subtleties about ACTH surgical disease, Cushing's disease, and hopefully I hope some people find some of this educational and interesting. But again, I just appreciate the opportunity to meet with you all and talk about something that I'm very passionate about. As was said, I'm a surgeon, a neurosurgeon at the Mayo Clinic in Rochester, Minnesota. I do have disclosures. None of them are relevant to this talk or should impact any of the advice that I'm giving through this talk. The objectives are to gain a better understanding of ACTH-dependent Cushing disease, understand MRI negative Cushing disease and what that is, which is important to a lot of the patients out there, and understand our misunderstandings and understand or misunderstand IPSS, which I think is an important distinction in this particular disease because it sometimes can cause some misleading things that occur within Cushing's disease, and we'll talk about that. So Cushing's disease syndrome versus disease. The syndrome is the process the body goes through after excessive exposure to this drug, cortisone, if made naturally, or its derivatives such as prednisone or other steroids that causes body habitus changes. It can cause a pendulous belly, moon faces, causes things like hypertension, osteoporosis, things that we'll cover in the next slide. But the disease itself was named after a neurosurgeon, Harvey Cushing, that if it was caused by adenoma found within the gland. This is how we look at Cushing's disease, in that when you present, oftentimes people can present with moon faces. They can present with buffalo hump, hair on their face, hirsutism in women because it's most commonly in women. They can bruise easily. They can have thin arms and legs, especially the musculature can be lost in the upper arms and upper legs, a large abdomen or central obesity, dark skin, muscle weakness. And the things that we really care about are the reduced fertility that occurs with it, the high blood pressure or hypertension, osteoporosis, and also the hypertension that occurs, the diabetes that occurs with it. When you present, we oftentimes then measure a blood marker called ACTH, which is what drives the excess cortisol. Usually it's a hormone that comes from the pituitary gland, although it can come from other areas in pathologic states. If that ACTH is normal or high, we call it ACTH-dependent disease. And then we go on to pituitary MRI. If we see a tumor, we say, well, that must be the cause. If we don't see a tumor, we then go on to oftentimes sample the blood coming out of the pituitary gland to see if that itself is elevated in ACTH. And if it is, we infer that the tumor is in the pituitary gland, even though we may not be able to see it. If not, we think it might be an ectopic pituitary or ectopic ACTH secreting tumor, most commonly carcinoid, that could be elsewhere in the body, making ACTH and causing this syndrome. If it's low, we won't spend much time about this, but that just means the adrenal glands themselves are making the hormone itself without being told that it should be made by the pituitary gland. And as you may be aware, especially if you had Cushing disease out there, there's no perfect test for this disease. There's low and high dose dexamethasone suppression tests, which can help us look for what we're actually trying to diagnose with this syndrome, and also demonstrating that the cortisone is not diurnally or during the daytime going up and down, that it's persistent exposure to excessive amounts of steroids. One of the gold standards, as you can see here, is a 24-hour urine cortisol, but that does miss patients, so the specificity is quite lower, the ability to completely diagnose the disease. And one of the best finds, or one of the best that we have, is late-night salivary cortisol, that makes susceptible to stress and other issues. But none of these are perfect, and sometimes it requires a leap of faith or a good endocrinologist. I work with an awful lot of them here at the Mayo Clinic. One such individual is Dr. Rena Boncos, who's able to make this diagnosis based on the clinical information, which is critical for us being able to proceed and treat the disease before it causes side effects. When people come to see us, this is an example of the type of evaluation that we do, in that we have this checklist that goes over all the symptoms that you could possibly have with this disease, and our fellows commonly check these off, and we check it. We look at the duration of disease and also all the lab testing that's done on the outside to see what we need to supplement on the inside. Here's just an example that leads into our discussion about what we're talking about MRI negative disease today, and that this is interpreted on the outside as being MRI negative. Now, when I look at this case, you'll see on this imaging that I've highlighted a small area in the inferior right gland that to most people would be called normal, but this is probably a tumor, and they can be very subtle. Now, this could be called, it doesn't necessarily change the disease situation or the outcome of surgery, but it's very important to understand that these are very difficult things to see sometimes. I include this slide because what we're talking about is using technology or imaging and other things to help us identify these tumors. And this is going back to 1983, before MRIs were really in use. People had CTs back then, but they weren't very good. And way back then, people still had really good outcomes. So this is a study from UCSF with a well-known surgeon by the name of Dr. Charlie Wilson, who reported 77% remission rates with selective resection of the pituitary tumors before they had all this additional imaging to help them make this diagnosis and do the surgery. So this is simply by doing surgical exploration with a microscope. And we have some reasons to believe that that's enhanced, and some other things have been enhanced over the years. It is important to note that if you have this disease and you have a measurement, that size really does matter. Microadenomas, so if we can see the tumor but it's small in a reasonable location, we have a very good chance of taking the tumor out completely with causing very little problems. If it's possibly visible or you truly cannot see the tumor on MRI negative, your cure rates drop to 50 to 70% based on the type of series we look at. So they drop just because we're uncertain as to where the disease is, which makes it less likely for us to find it when we go looking. And just so you're aware, as the tumors get larger, they become harder and harder and harder to cure, because they can invade structures like the cavernous sinus, which is an area next to the pituitary gland that houses important vessels and nerves. And as a group, the cure rates are approximately 50%. This is an example of a paper that we published just in 2024, looking at this in a different disease, acromegaly, which more commonly presents with larger tumors, just showing that if you have a tumor greater than 15 millimeters, so a macroadenoma is designated as 10 millimeters or greater, and if it has various grades of infiltration into the cavernous sinus, there is a much lower chance that we can cure you, and it may need additional treatments like medicines or other surgical options, or potentially radiation for treatment. And that's critical in order for you to understand what your individual risk is of needing additional procedures in these cases. MRI negative Cushing's disease occurs in approximately 40 to 60% of cases. You have a higher chance of not curing you. There is no official definition for MRI negative. We use outside or inside MRI read that was called negative. However, this is in the eye of the beholder. And just so you're aware, as a pituitary patient, if you have a radiologist calling a tumor, this is becoming more and more common, that they're saying there's something there and there isn't. So I see a lot of patients in a week that come in and say there's a pituitary tumor. Their patients are undergoing pituitary workup and they're completely normal, and they're saying there's a tumor. The reason is the 3T and 7T MRIs that are being used, so higher resolution imaging, there's natural differences in how the gland looks. We call that heterogeneity. And some people may misinterpret these as tumors. And that same thing happens, obviously, in Cushing's disease. There's also interesting imaging pitfalls in Cushing's disease in that what we call an empty cella. So in Cushing's disease, the fluid builds up outside the brain and pushes on it, but it also pushes on the pituitary gland to flatten it like a pancake. When we try to look at it or look for tumors, this normally big structure is less visible, and it creates an issue in terms of trying to find a tumor. So just so you're aware, there's a fairly high percentage of this occurring where you're unable to see the pituitary gland. Now, we like to use advanced imaging to find the tumor or give us ideas of where to look, so we're not having to cut out all the gland or cut through all the gland and trying to keep the normal functioning pituitary gland intact. There's things like dynamic imaging 3T, higher resolution 7T, which we'll touch on in a little bit, photon counting CT, which we'll also touch on. But we want to make sure that when we're reviewing the images, we look at some odd areas like the cavernous sinus or the connection between the brain and the pituitary gland called the stalk, that there might be a tumor there, which are abnormal locations. Methionine PET we'll cover in the next slide, but that is a type of PET scan that's not available in the United States. And once in a blue moon, a patient with a lot of resources, we send people over to Germany or other places to potentially receive one of these scans to see if we can help in very, very difficult cases. FET-PET is a trial that we will be opening up here at the Mayo Clinic shortly that should be able to do exactly what MET-PET does and identify these tumors, but can be used for a variety of different diseases. And of course, the insurance will try to stop all this extra investigation. But we call this non-invasive investigation important in order to help us understand the roadmap for success at surgery and how we can help you best. By getting this additional imaging, even though it can be painful in terms of scheduling and whatnot, we're hoping that we kind of catch lightning in a bottle. We find the spot that we have the most likely area that we can get to this tumor. Now, this example in the upper left corner is just an example of an experimental MRI sequence that we've been using that demonstrates what looks like probably a small pituitary tumor in the mid gland here in this patient. This is data that was from Japan, published in 2023, showing some of these examples of some tumors that are more obvious in this particular circumstance, that show how the methionine PET works in these cases. Now, I will note that sometimes they find these things in areas of bone that are outside the pituitary gland, and that's why just going and removing the whole gland doesn't work for everybody. And it's important to know that with a scan like this that may light that up. The future is coming in that we'll be using deep learning, where the scan itself will be able to look at the quality of your scan while you're on the scanner to improve the potential of finding a tumor. Now, it's possible that it actually results in, again, more overcalling or observation of spots that may not be tumors, but we don't know that yet, but we believe that is what's coming. This is something that we published, and I won't show the video in this particular presentation, but just showing how a 7T MRI and using intraoperative ultrasound, different types of technologies may help improve the chance of finding a tumor and taking that out. And this is available in operative neurosurgery if someone would like to see it. But we get commonly the question of, well, a 7T MRI, wouldn't that be better? It's higher resolution. When we review the literature and look at our own institutional experience, it does help in a small percentage of patients identify tumors that we wouldn't have otherwise seen, but there are problems with it, including the potential slice thickness and the potential resolution and the artifacts or problems that can occur with this type of imaging that have not made it the holy grail. Again, it's a good tool. It's helpful at the centers that it's available with, and I would recommend if they don't see a tumor undergoing the scan. But everybody can't use it. and it may not be the silver bullet in this particular section. There's a common practice that occurs out there with what's called IPSS guided hemihypophysectomy. What that means is you go and get your IPSS sampling. If one of the two sides shows that there is more hormone on that side than the other, they go and they take out that side. I'll just warn that this is not what the intention of the IPSS is. And what we found over time is that this is actually not the correct way to do this. We found that there is that IPSS is simply as it was intended to do by Dr. Oldfeld in the NIH, just identify patients with elevated ACTH within the gland. When we look at lateralization, it doesn't work. It may work in a small percentage of patients, but not in everybody. And when we take all the literature out there and look at what did it help localize a tumor or not, there was absolutely no correlation with its use and the overall outcome for patients, which was published in 2024 in World Neurosurgery. Now, given these problems, we've come up with some very modern solutions. So this is my partner, Dr. Ian Mark. He's a radiologist. The problem is that MRI negative Cushing disease is a problem. We're unable to detect the pituitary adenoma up to half of patients with Cushing disease. And the cellular MRI is an extremely challenging, predominantly due to the small size of the pituitary, as well as artifacts that happen around this area where there's a lot of air. And the slice thickness only goes down to, at best, 0.75 millimeters. And the gland itself, at most, is 12 to 14 millimeters. So we could only sample it 4 or 5 times slicing through it. The solution that we found at our shop that's more recent is photon counting CT, which is a completely novel technology. Photon counting CT works like this. So the old way of detecting was called an energy integrated CT or detector CT. And this is an example of a temporal bone CT showing the same picture between the two of what's called the stapes bone. You can barely see it here. And the way this technology works is, let's say there's 10,000 photons that are fired into the body, and we're detecting them on the other side or the head. This thing has a plate that picks up a certain percentage of those, and then it activates if only a certain percentage of those are seen. That reduces the resolution of the imaging. So therefore, this new technology says, well, let's just count each photon that's going through, and let's have an individual detector for each one of them and cut out the middleman. And that has some pretty amazing things. And it allows smaller detection and significantly increases the spatial resolution. So what that means is it improves the ability to see smaller stuff better. It eliminates a lot of the electrical noise that we were having before, which had to do with those plates. And it reduces the contrast due to the increased detection. And overall, the amount of radiation received from a treatment like this is almost 85% lower when we do that. So recently we reported this series of patients that we use this technology. So I said to Dr. Mark, you know, if the CT has 1/8 to 1/10 the dose, maybe we can scan more frequently. And that's how contrast dynamic CTA was born, in which we give some contrast and we measure the pituitary gland at different time intervals after. And it's able to help us understand what might be pituitary and what might be pituitary tumor. It turns out that, interestingly, this was something that was explored in the 80s and 90s as MRIs were coming in, and actually did quite well, but the dose of radiation was quite high. And they thought MRIs might be better than this. So this might be a solution. This is this particular scans that we use for this. So very thin cut, 0.2 millimeters and 0.6 millimeter thickness. So very small. We can sample the gland an awful lot of times. And these are examples of MR negative cases that clearly show small pituitary tumors. In this particular patient, these dark areas that would have been otherwise unseen with an MRI. After processing, so we can actually process this with looking at different scans and doing what's called an iodine subtraction scan, we can actually see these areas of darkness which correspond to tumor. In 20 cases that we're reporting, we found 20 tumors, and a lot of these were previously operated patients. And this is another example of a similar finding in a patient with an empty cella. So the pituitary gland is pancaked here, and there's a small pituitary tumor on the left side of this patient. And we're starting to do more detailed anatomy and understanding things better in terms of how we can surgically address the area based on this really cool technology. So going on to surgery. So surgery for a ACTH secreting tumor, whether it's not visible or not, if you're interested in this kind of stuff, we just edited a journal, a full issue of a bunch of techniques that we use in MR negative Cushing disease that was published in 2024 in Neurosurgical Focus. I'd encourage you to go look at those videos. They're really good, and they may help you understand a little bit more about this, and we'll show one of those coming up. So prior to surgery, we assess the DVT risk. If it's low, I use some things inside the operating room to try to reduce bleeding, and the point of that is to try to reduce scarring and postoperative nasal complications for you. And that happens a lot because the way Cushing's disease works is it makes the tissues real easy to tear, you're easy to bruise, and things bleed a lot more. If we can reduce that at the time of surgery, our thinking is that we can improve our overall visualization of the tumor, but also improve your nose outcomes after surgery. If your risk is elevated, I typically do not use this TXA protocol, and oftentimes you'll see that you'll need postoperative venous thromboembolism prophylaxis or blood clots either in your legs or your lungs. We want to try to prevent that, which is a problem with these particular tumors. We like to optimize patients for surgery. However, we don't want to wait long for surgery. We call this an urgency, not an emergency. We typically get people on the schedule sometimes the next day, but most commonly within 7 to 14 days for this particular operation. This is an example of the protocol we published using TXA in the operating room, which is again helpful for reducing nasal bleeding and improving the overall nasal outcome post-operatively. When we do surgery, we go in and we expose the pituitary gland. This is a cartoon of what's happening. So in the central part is the pituitary gland itself. The ghosted yellow area is the posterior pituitary gland, which we don't think these tumors occur from. These yellow structures up here are the eye nerves. This bluish area is an area we call the cavernous sinus, which sometimes a tumor can enter into. And these red structures here are the carotid arteries on each side. These are at risk with surgery, but they're uncommonly impacted. In fact, in my career, at least of 1,200 pituitary operations, I've not injured one yet. And Cushing's cases are probably the least likely to injure these, by the way. We expose the pituitary gland. We usually expose from cavernous sinus to cavernous sinus. We then take a hook and palpate the gland. We use intraoperative ultrasound, which allows us to look through the gland in a non-invasive way to see if there's any areas that are problematic or could be tumors, especially if we don't know where it is before the operation. And it oftentimes gives us more confidence that the imaging we had done before is appropriate and actually tells us where the tumor is. So it's very helpful to do that inside the operating room. And then we test our hypothesis, the ideas we had from the imaging, and we explore. If we find the tumor, we go ahead and remove it. What we're looking for is the gland is different colored in Cushing disease. A lot of the cells that make ACTH, because the body feeds back with the cortisol, shrivel up and it makes it look yellowish. This is what's called Crookes changes, and there's changes in texture that we look for. So this is a pituitary gland that's been exposed with Cushing disease. You can see it kind of how yellow it is. And I think this is one of these things that really takes experience to understand and see, because most of the time the pituitary gland's a nice beefy red, which it just isn't in this case. When we find a tumor, the best technique for removal, and this is just as uncommon, so I'll point out this is one of the masters of surgery for this. Dr. Oldfield is unfortunately now deceased, but he looked in a series of 261 patients out of his total series of 1,500 patients that he was able to identify and do a pseudocapsular technique that's find the tumor and go around it by taking a little bit of additional pituitary gland. And when he was able to do that, 97% of patients went into remission after the first surgery, which is a super high percent. And then Anybody that had any persistence with reoperation, they went into remission, and 2% of patients had recurrence with this long term, which is really impressive numbers for this particular problem. What he also went on to show is that on really small tumors, they're very hard to see because they don't develop a capsule or crushed pituitary gland on the other. And I do think there's soft pituitary tumors that don't look like lesions, and they just flow through the gland. So this is an example of, I just show people that, you know, I think when you're younger trying to learn this, you're looking for a little ball. This is a pituitary tumor. So this is, you'd say, well, is it this thing? Is it this thing? When we stain this, it's this dumbbell mass is actually the pituitary tumor kind of swimming in between the gland. And the gland is set up in a channel of little areas that can actually block flow of these things, and this thing can flow through the gland, and it's very important to identify these areas and try to remove it all. So it isn't necessarily a distinct ball we're trying to take out of patients. I will make the point that surgical decision making is age and sex dependent. If I go in and then find a tumor, I take it out and I stop. If women who would like to have children in the future, we may explore a little bit of some of the gland, but generally we stop if we don't find something. In all other patients, such as males or patients that are done having children, I then go on to do a subtotal gland resection. This is a technique that I learned from Dr. Lillahai, this is a nice paper that showed in 22 patients. They couldn't find a pituitary tumor, so what they did was resect a certain proportion of the gland, and 82% of patients achieved remission, and 10% had postoperative new deficits with the pituitary gland. What you do with this technique is you're just trying to take out a certain percentage of the gland, generally 70 to 80%. And we think by doing that, we're playing a numbers game, that we're having an 80% chance of putting someone into remission if we take out 80% of the gland. And we're hopeful that it will be able to maintain pituitary function, which is a very important aspect of things. And it's been proven time and time again that this technique can do that in a variety of ways. This is a video of how this is done. We go in, we identify that pituitary gland. What I do is I identify it in thirds and take out the outer third on both sides and the bottom 25%. And the idea is that we'll be able to preserve the posterior pituitary gland and the central core that can still work. This is why we don't do this in patients considering fertility in the future, because we don't know what the impact would be on having a pregnancy and having a normal pregnancy. But in all other patients, this is a very good technique. And this is what the pituitary gland looks like after that type of an operation. So before surgery, there's a nice large pituitary gland right here. And after surgery, you can see it's a little bit more pancakey, but there's a good amount of tissue there. And this patient had no detectable postoperative pituitary dysfunction and went on to remission. There is this concept that not all things that are causing pituitary Cushing's disease is coming just from the pituitary gland, that perhaps the brain is making a substance called CRH excessively, and it goes down to the pituitary gland and tells that to make more ACTH than normal, or there's something wrong with the way that it's gauging the amount of cortisol in the body. And in those patients, it seems as though there's a good chance that a subtotal gland resection will result in an overall good outcome with reduction of the side effects and symptoms of Cushing's disease and cure if this technique is used. So in these patients, there is no tumor to remove, and we're not taking out all the cells either, but it seems like it's a good technique to try to address this problem. Men in Cushing's disease are very uncommon, as this disease is certainly more common in females. Men present in a completely different, what we call phenotype, or different way. They oftentimes have multiple fractures. They may be unable to walk due to proximal muscle atrophy. So I've had patients come in a wheelchair because they just don't have the strength to get up the stairs or to walk. Oftentimes patients are much sicker. In patients that can't undergo surgery or are too sick for surgery, we have other options like freezing the adrenal glands to try to get people into remission, so they're safe enough to undergo surgeries that may address the pituitary tumor or other issues associated with the disease. But men in Cushing disease represent a much more aggressive type of disease and are very unique. When we do this type of an operation, it's important also to note that it's not uncommon for people to have two pituitary tumors. So this is a case report with my Professor Shinyu, who's in my research lab and is a surgeon from University of Tokyo, in which this is how these pituitary operations are done. So this is, I'll just fast forward to show some of the pertinent history here, this 4-year history of ACTH-dependent Cushing disease. The prolactin was elevated, which is a clue that there might be more than one tumor or a tumor that's making more of something, both of these. And when you look at the MRI, there seems to be some thickness to this side, although this was right as MRI negative. And there probably is something separate here. And they could be the same tumor, they could be different. We ended up going to an endoscopic resection rather than a microscopic resection. I only do endoscopic resections. As we said, the risks are CSF leak, carotid artery injury, the normal risk, the potential for pituitary damage. But the upside is, getting back with no medications down the line and alleviating some of the problems that we can see with these, with this long-term disease. So we'll just get forward to where the operation is happening. So we're identifying the pituitary gland and exposing it completely. And then we're going to make sure that we're seeing both sides, what's those cavernous sinuses or those areas where those carotid arteries are living. And then we're going to open the dura very carefully in order to not disturb the pituitary gland. So that's what we see here. And we decompress it to allow it to get bigger. So sometimes we can see little bulges or areas where these tumors can be. And then we cut into this outer surface. And I'll show you in a second here that there's pituitary tumor right behind this. So this is the normal gland that we're pushing up and away and developing a plane. And then all of a sudden we find behind it a separate colored tumor, which ultimately turns out to be the prolactin secreting tumor. So there's the ACTH tumor we're pushing up, and this dark tumor is a prolactin secreting tumor. So after we have a good area around it, we're going to debulk it. So take out some of the tissue and send this separately. And then we're going to work on this other tumor that's into the gland. So we took that other tumor to give ourselves room to try to preserve the pituitary function the best we could. And so here we're kind of pushing the normal pituitary gland away from this tumor, but it's quite large, surprisingly. So we're going to take the front end of it off to help us see behind. And these operations require a lot of patience, but this is what that Cushing's tumor looks like. And this is different in that it's a very firm tumor. Most of the time they're very soft or liquidy. Now that's the rest of the tumor right there, that very yellowy appearing thing is the tumor. And then we're going to take a scissors out and we're going to cut away the areas that were touching the pituitary gland actually down to normal pituitary gland. And just make sure everything looks normal before we're done. Now here we're inspecting, that's the posterior part of the pituitary gland, and we're inspecting the backside or the walls of the cavernous sinus and making sure there's no additional disease there. And we thought we saw a little bit of a piece back there, which we then removed. Put a little bit of absorbable gel foam, which is collagen, a little small piece of skin from the bottom of your nose so that you can't see, it's inside your nose. And then we put a little tissue glue up there to hold that in place. And in this particular circumstance, both the prolactin and the ACTH dropped immediately after surgery, and the patient ultimately remains in remission still, now 2 years out. This was commonly seen, so this is a paper by Dr. Oldfeld showing that this is not an uncommon occurrence where there's ACTH and prolactin secreting tumors. So we're always on the lookout for these types of things. But in this series of over 300 patients, 13 patients were found. So I think it's important to be aware, and it's important that your pituitary surgeon be aware of this. It's also important nowadays to have modern skull-based techniques. And what I mean by that is back in the days, we would just cut out parts of the pituitary gland. Now we're actually taking out everything but the carotid artery to try to enhance the chance of surgical cure and reduce the chance of needing medications or additional treatments in the future. This is an interesting case of a patient who had pituitary-dependent Cushing disease and had a preoperative apoplexy. So this patient presented in 2012 with substantially high urine cortisol, and they had this large left-sided tumor. The patient, prior to surgery, called with nausea and felt very sick while they were waiting for surgery in town. And ultimately, they showed that the cortisol dropped, and they actually had apoplexy resulting in cure. 6 months later, that tumor resolved. What happened over time was the patient's tumor came back and their Cushing disease came back after 12 years. We went back to surgery and removed everything adjacent to the artery. So what we see here is a carotid artery, the pituitary gland, and all the dura is removed, and there's this big open area where that pituitary tumor was sitting or recurred in the cavernous sinus. And this is what this looks like after surgery with it completely removed. This is another example of an interesting case and kind of highlights what the IPSS was before. High levels of midnight salivary cortisol. The dexamethasone suppression test, the high dose didn't suppress completely, and there was a low urinary cortisol 56. So we decided that we would, there's a historical image of having a left-sided pituitary tumor with a normal-looking pituitary gland back in 2014. But now, based on what the MRI showed, we went and did a IPSS just to confirm that this was from the pituitary gland, given how long that tumor had been there. And this is what I was kind of explaining before. The right side demonstrates what is significant elevation. Now recall the tumor's on the left side, and the left side is completely normal. And this patient had a type of a filling pattern that would fool, I think, people, and they would take out the wrong side of the pituitary gland. When we look at the most recent imaging, there's no way you can see a tumor because the sella is now compressed. There's an empty sella, and the pituitary gland looks like a pancake. Even on our experimental MRI, you can't really see anything. This goes back to that dynamic CTA. We performed that, and you can see a left-sided tumor. We brought that patient to surgery and removed that tumor, and their post-op day 1 AM cortisol was less than 0.1. When we do these operations, how long do we wait for suppression of less than 2? Most commonly, it happens on post-operative day 2, although some people believe that it needs to occur on post-operative day 1. I see in my practice most commonly post-operative day 2. In the documented literature, the furthest out I can find is 10 days of where it's suppressed, and the patient ended up being in a long-term remission. But I always say 14 days, the data last call, that if we haven't had you in remission in the first 14 days, it's really time to either consider going back to surgery and taking out more pituitary tissue or getting bilateral adrenalectomies. There are some in-betweens in which we do some delayed testing at results. It ultimately gets down to how definitive the diagnosis is preoperatively. It is also important that even if we show your cortisol dropped and you have symptoms, so if you get on supplementation, we still do some delayed AM cortisol testing to show the nadir, because less than 2 micrograms per deciliter is a good prognostic indicator for long-term remission, according to this paper out of UVA that demonstrates this quite nicely. So post-op, what do we do? Well, not all excessive urination is DI, so diabetes insipidus, or now the new name arginine vasopressin deficiency. We expect you to pee out more, after surgery, because the way Cushing's disease works is you're holding on to salt and therefore water. If we get rid of that driver that holds on to salt, you'll get rid of that sodium and chloride and water. So when we cure you, that's oftentimes what happens. I tell people, don't let the residents just treat this with DDAVP. We do it based on what the sodiums look like. So elevated sodiums we treat with replacement of arginine vasopressin deficiency. You'll see a variance in how people use hydrocortisone over prednisone after surgery. There is a movement towards using more prednisone because it's easier on you to take. But just know that hydrocortisone is commonly used if people are diabetic and their hemoglobin H1C is over 7, because it avoids the high glucose spikes that can occur. If you're not diabetic, then prednisone seems to be better. It is really common for steroid tapers to stop between 3 and 6 months. Some people don't get off steroid supplementation because the pituitary gland doesn't recover. When do we want to explore? We want to re-explore early. If we found a tumor you didn't drop, that means we didn't take it all out. Or if the pathology is negative and there's no remission, it's important to think about going back to do either the subtotal gland resection or something to get on with the surgical remission of the disease. And also the scarring can make it more complicated and make it a higher risk as the longer we wait. So there's a 71% chance of remission if we go back for return, according to this paper with Dr. Oldfield, which is a very good paper about this. So in patients with persistent disease, if we go back again if we've gotten your remission and we found a tumor there and we take you back to surgery, if you recur in 5 or 6 years, the chance of remission then again is quite high, 72%. So it's absolutely worth considering doing surgery if you have a recurrence of disease. So what if we fail? If no tumor was found, we go on, and you certainly have Cushing's disease, we recommend bilateral adrenalectomies. If there's unsure diagnosis, so medical therapy is helpful, or observation. Sometimes the endocrinology team becomes less and less sure about what the diagnosis could be, and doing more testing might be helpful. If we found a tumor, however, it's not completely resectable due to invasion or other factors, we would then think about stereotactic radiosurgery or medications. This paper was done by Dr. Sheehan, looked at patients that received Gamma Knife or single session radiation after treatment. Gamma Knife is a brand name of that. And it just showed that the earlier we do it, the more successful we are in remission postoperatively by increasing the chance of going into remission, rather than, it makes intuitive sense that if we wait longer, we let the tumor grow back and there's more tumor cells to treat. And there's some things, and this is a quick case of a 33-year-old with severe diabetes. This is a male, and I said they present more dramatically. Well, this patient had type 2 diabetes, bad hypertension, high blood sugars in the 700s, and they had opportunistic infections because their immune system was suppressed by steroids. They thought their MRI was negative, although it looks like in retrospect there was a small pituitary tumor. The 24-hour urine cortisol was as high as I've ever seen it, 96/25. Huge numbers for midnight salivary cortisol, and all the symptoms you can think of. So this patient went on to adrenalectomy, and ultimately what you see is the ACTH elevating over the course of about 8 months. And so they looked again with the dotatate PET scan, and what you see is that the dotatate PET scan, the intensity goes down because something happens with the pituitary gland. And in the course of 8 months after the adrenals were removed, there was this massive recurrence of tumor that ultimately, this is a whole different situation. These can be aggressive tumors. So we went back and removed not only the tumor, but also the gland and actually some of the stalk that went up into the infundibulum. I'll spare you the video on that. But that's what's called Nelson-Selassie syndrome. There's a small percentage of patients that can go on to have adrenal resections in which the tumor becomes very difficult to treat because it grows, because the cortisol itself tells it to not grow. And something that you need to be wary about if you're going to undergo a bilateral adrenalectomy. It's important to understand that. Curious case of cyclical Cushing disease. Cyclical Cushing disease definitely occurs. This is a 49-year-old that was thought to have post-COVID chronic symptoms of easy bruising, weight gain. She found it hard to walk upstairs and bike. She developed some bad cystic acne. She was bad 1 month and then she'd be off the next. April, she had normal midnight salivary cortisols and urinary cortisol. August, she was very symptomatic and had a really high urine cortisol of 834. September, she came and visited, and there was 2 times normal midnight salivary cortisol. So we said, go home when you come back and you're symptomatic. She came back and she was symptomatic, and she had a positive IPSS at that time, proving that this was probably pituitary source. You can see here a buffalo hump and some moon facies. This is her MRI demonstrating a very small pituitary tumor just under where the stalk enters. We took this patient to surgery and removed that completely. Her AM cortisol didn't drop as much as we would expect in her, and she did not have prolonged adrenal insufficiency. And I use this because patients with cyclical Cushing's disease can be a little bit different in that because they're used to recovering intermittently, they actually don't suppress normally like some of the more severe cases we see. Good news, so you do lose brain volume with Cushing disease. It's been shown that if you can cure the Cushing disease, the brain volume rebounds and things go back to normal, which is really good. It's one of the recoverable side effects that we see. We are currently in the stage of collecting all this data prospectively in a large pituitary registry. We're also involved in a consortium with 21 pituitary centers across the country, looking more at Cushing's disease and other things like this. But this is leading to high resolution data, and this is by my partner and lab mate, Professor Shinya from the University of Tokyo. And what we've done is we're taking all of this data, and I'm going to go through this quite quickly. And we're taking all of this data, including radiomics and AI and machine learning type of stuff, and we're trying to figure out if we can help predict for you what your outcome could be from this disease. And the aim is to establish a machine learning model to predict long-term biochemical remission and also to predict some of the side effects that one can see. We hope at some point in time to provide some online calculation tools that you can use no matter where you go to try to understand your risk to disease. But the way it's currently going is data collection with supervised clinical data and image data, segmentation, extraction, and radiomics mixed with clinical data, and using machine learning algorithms, which we'll discuss in my next PNA lecture, about how this could impact you long term and how this could help you do better. But what this shows is that maximum tumor diameter, the ability to achieve a gross total resection, age actually impact quite a bit the diagnosis, and this puts us in a stratification in terms of how well you could do with surgery. It tells us a tumor like this tumor right here is just unresectable. It puts us into a category in which we can figure out what the best combined multimodal treatment is and let you know that you might need more than one treatment for surgery. And it also tells us which cases we'd expect to have surgical cure for. So in the end, I'll just conclude with in Cushing's disease, we want to confirm the diagnosis, understand the imaging, if the tumor is seen or not. Surgical risk mitigation is important. Watch out for DVTs. Hemihypophysectomy, I'm warning, don't do it. IPSS isn't helpful in guiding that. And never give up and get to surgery at your earliest convenience. And that is my talk. How do I stop sharing?
Thank you so much. That was awesome. We do have a few questions for you. We will start with question number 1. I had endoscopic surgery and pathology came back positive for ACTH tumor with Crooks-Hyling changes of non-tumorous pituitary, but unfortunately did not get into remission. A reoperation 8 months later, also had a resection of tumor with positive pathology in cavernous sinus and was in remission for 2 years, but again experienced recurrence, confirmed biochemically, and subsequent 3-interval MRIs for past 2 years have not shown any tumor. What imaging tests are recommended to localize the tumor at this point?
That's a very tough situation, because without seeing the imaging, it's very hard to know what it looked like before, because most of the time we would, it sounds like it'd be hard to consider to do more operations. It seems like medications or gamma knife mixed with adrenalectomy will be ultimately recommended because surgery is proving to be quite difficult. But it would be good to see the imaging itself. Now, I don't think any of the modalities that we showed are going to help any more than a plain old-fashioned MRI. I don't think the photon counting CT will help here because there's going to be surgical scar, which will be difficult to distinguish between what a pituitary tumor might be in those circumstances.
Okay, thank you. The next question is, at what point do you recommend BLA be performed for Cushing's disease?
So I don't typically recommend that. I mean, I'm not saying I don't. I think it's a great technique, and I think it's really important because ultimately stopping the disease is the most important thing that in terms of long-term outcome. We work in teams here, and my job is to present the risks of repeat surgical resection and the potential likelihood that a repeat surgical resection would be helpful. Now I don't make any more money for doing procedures here because at the Mayo Clinic we're all on salary. So we all meet as a group, and a lot of times the endocrinologist is driving the decision, but we also talk with the surgical team or the general surgical team that does that to understand what the risks and rewards may be in those particular patients. But for instance, this week we had a patient that was sent up here that had surgery at a well-known East Coast facility and had a repeat operation at a well-known Midwest facility. In this singular patient, she had an empty cella, and it looked like she had difficult bone to maneuver through that wasn't removed adequately. So we did repeat a CT photon counting exam on her and thought there was a tumor on the right side and went back and removed that, despite the fact that she was recommended for adrenalectomies. Now we found a tumor and she went into early remission. But most of the time, I think the discussion of adrenalectomy, it's the quickest way to get to definitive cure, and also don't have to worry about recurrence in the future. So when we have a difficult situation in which we don't think the chance of cure with surgery is highly likely, adrenalectomy is a very good way to get people into disease remission. And usually we can manage, if there is a pituitary tumor, what happens with that over time and try to reduce it from causing other problems. I don't know if I answered the question well enough, but I think adrenalectomy, I don't make the decision. I don't recommend. I participate in the decision process, and we are very realistic about doing it. And in the first 2 weeks, if we've done the best we can or maximized our surgical procedure endoscopically, we then recommend getting adrenalectomy quite quickly in order to get control of the disease.
Okay, thank you. Our next question is, where is the outcome study located?
The outcome study, are you talking about the machine learning data that we published? If you are,
I believe so,
I don't
yeah.
know. If you are, that study is published in JNS in 2025. So 24, it just came out this past summer. But we hope eventually to provide online calculators for you, no matter where you go, to get some idea of what the potential risks and benefits of surgery might be.
Okay, great. Thank you. The next question is, I had surgery last January of 2024, and immediately my cortisol levels dropped to undetectable. I've been on hydrocortisone since now at 15 milligrams and showing no morning cortisol 15 months later. My thyroid levels are normal. What's the longest time you've seen for the ACTH to start up again if everything seemed like a successful surgery?
So I will be honest with you, I don't see people on that end. I know there are people that don't recover, but the endocrine team usually takes care of that. I don't have a good, I'd just be making it up if I told you something. So I think that I wouldn't give up hope. And sometimes it might have to do with, they might want to switch over from hydrocortisone to prednisone, but I'd ask, I think it'd be worth consulting with a separate endocrinologist to see if you can figure out if there's something else that could be done to see if they can stimulate and get your ACTH back working.
Okay, thank you. And our last question is, when would medical therapy be preferred over surgery?
So there's a couple of times in my time I've seen it before. I think so during the pandemic, when we were unsure if we could do pituitary surgery, we did use medications quite frequently, and they can be good in the short term, but the long term is that the tumor is still there and the medications have a lot of side effects. We certainly use it in cases in which patients are unsure of the diagnosis, and we may need more time for the Cushing disease to be able to develop to make sure that we can see it. There are times that the endocrinologist will use it, especially for mild Cushing's, but the medications are difficult to use, especially for really moderate or severe cases of Cushing's. And again, I'm not an endocrinologist, I just see a lot of it. Our preference here is not for medical treatment because, we want to get the disease treated permanently and get it under control. But I'm sure there's other webinars that the PNA has that you could see online too as well to see that.
Okay, thank you. That's all we have today. Thank you again for
Awesome.
an amazing presentation today. We really love when you come out.
Well, I love doing it, and in the fall, it sounds like we're going to try to do a machine learning, AI, and big data. What that means for the pituitary population. It'll be a little bit interesting, I think.
That sounds great.
So stay tuned. Thanks again.
Awesome.
I appreciate
Thank
it.
you.
Okay, bye-bye.
Bye. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us and enjoy the rest of your day.